Good evening and welcome to DePaul University. My name is Michael Buddy. I'm a professor of Catholic Studies and a senior research scholar in the Center for World Catholicism and Intercultural Theology, which is a research institute here in DePaul that studies the Catholic Church as a transnational phenomenon with special attention to the churches of the so-called Global South. I'm very glad you could make time for us this evening, and we hope you have an enjoyable time. If you would like to avail yourself of food or beverages during the please feel free to do so, as long as you're appropriately discreet and quiet about it. Thank you. This evening marks the last event this year in a series that we've done over the last 2 years focusing on the works of mercy in the Catholic tradition. Corporal and spiritual works of mercy, classic markers of Christian faith in action. Clothing the naked, housing the homeless, visiting the prisoner, and this evening, caring for the sick. Our guest this evening has an extensive bio that has been provided to you on your chairs. Rather than read that to you, I commend it to your attention. David Gaus is what happens when you're on the way to a promising career in the upper middle class as an accountant, and suddenly you have a crisis of conscience that sends you into serving the underprivileged in another part of the world. You go back to medical school, and while that might have made my mother happy, she would have no doubt been equally frustrated to find out that the medical focus would be tropical medicine in Ecuador. So he's the founder and head of a nonprofit organization called Andean Health and Development, which is pioneering new and innovative ways of structuring healthcare, particularly in rural areas in Ecuador, with implications and possible lessons for delivery of services, which sounds too antiseptic for what they do, according to my understanding, to provide a more holistic measure of compassion, accompaniment, and medical care. David has 2 undergraduate degrees from the University of Notre Dame. He has a medical degree and a master's in public health from Tulane University's noted medical school, which focuses on tropical medicine. He's here today to talk to us about missionary medicine, and he will describe what that is, and its practice, understanding, renovation, transformation in the era after liberation theology. We'll have time for some questions afterwards, but please join me now in welcoming Dr. David Gaus.
This is Senor Agua Civil. He is a gentleman from the Santo Domingo tribe, close to our second hospital. And his son Juan came into the hospital with a very high fever and body aches and a headache. It was going on for about a day and a half before he came in, and we admitted him to the hospital, and our residents, our Ecuadorian residents, were figuring out the differential diagnosis, including things like dengue and chikungunya and malaria and typhoid fever. And his son Juan was really quiet. He didn't say much. And the perception was that he wasn't believing in what we were trying to pitch him, what we were trying to tell him what his problem was. The next day, an attending physician came into the hospital to see him, and immediately had the same perception of the patient as our residents did. The attending physician knew his father. Turns out his father is a healer in the community. And so Diego immediately asked his son, "Did one of the arrows hit you?" And he finally, for the first time, made contact with a healthcare provider and didn't say much. And Diego said, "So your father's a healer, and of course you have a fever because one of those arrows that people send to healers in a tribe to try and attack the healer bounced off of his reflective shield and landed on you. And that's probably that's why you get your fever, isn't it?" He looked at Diego and finally nodded. Later that day, Some of the tests came back for the differential diagnosis that we had built for him, and we discovered that he in fact had dengue. He needed another day of therapy to make sure that he didn't have the complications, but by then, he was on board. He was on board. So why do I tell you this story? I tell you this story because one of the most important things I want you to get out of this discussion tonight is the importance of context. Is the importance of context. And I'm tying it to liberation theology for the following reason. So I'm not an academic liberation theologian. I was around in the late 70s and the early 80s when liberation theology kind of became a thing in the literature and a thing in Latin America. I was an influenceable undergraduate student and was very interested in the role of the Catholic Church in Latin America, and began to study a little bit liberation theology, read a book by Gustavo Gutierrez, which you probably all have heard of. And so I will tell you that in summary, liberation theology in many parts of Latin America where it did happen, happened for many reasons, but not the least of which was because large communities, sometimes hundreds of thousands of people belonging to a parish, had no access to priests. And so they took it upon themselves to interpret the Bible and to interpret the gospel. And whether or not through these Christian-based communities, and whether or not you agree with that is subject of debate, and there's all these issues of Marxist ideology and all those other things that kind of got in the way later on. But the important thing from this experience that I saw, that I perceived, was the ability of people to put their faith within the context of their own lives. To the same extent, we felt it was critical, and I believed it was critical, to make sure that healthcare is also put within the context of people's own lives. And so this was really the concept behind this. The other issue was the issue of being critical. One of the things that was discovered in liberation theology was that when people did study the Bible and think about it and apply it to their own context, they came up with some very uncomfortable questions that really challenged conventional wisdom. And they uncovered many conflicts, and they did a lot of critical thinking. And so critical thinking also became an essential part of liberation theology. To the same extent, one of the other things that I really want you to get out of this talk, in addition to the importance of context, is critical thinking. And by that, what I mean is we train physicians in a program in rural Ecuador not to be just physicians, but to really critically assess their healthcare system in their own country. Because we want them to be transformers of their healthcare system and not just innocent bystanders working within the system. Good evening, my name is David Gaus. I'm from Milwaukee, Wisconsin. I've been living in Ecuador for about the last 20 years or so, running an organization that tries to provide healthcare services in rural Ecuador and to train Ecuadorian physicians. I thought I'd start off just by taking a minute or two to talk a little bit about, as Michael had mentioned earlier, why this happened. And the really short, abbreviated version of this is that I went through my midlife crisis at the ripe young age of 21 years while I was a junior and senior. In undergrad, I was a fairly profoundly disturbed individual, looking for some guidance. I was an accounting major and went home the summer after my junior year in college, not sure, knowing pretty well that I did not want to be an accountant, but actually entertained everything from becoming a priest to becoming a fighter pilot in the Navy. Neither of those two other things worked out, and in the end, I decided to went to a university that really focuses a lot on social concerns. There's a lot of social activism, in our university. I had not been much of a participant in that during my 3 years previously in undergrad, but had done some of that in high school. But eventually, I became more and more interested in this, and specifically in the role of the Catholic Church in Latin America. A lot of my classmates were doing volunteer work. In the end, I decided to join something, not quite JVC, Jesuit Volunteer Corps, but something along those lines, and went to Ecuador and worked in the family development project there for 2 years. While I was there, I met a guy doing tropical disease research, playing basketball at some gym and some missionary school, and decided that it was appropriate to think about going into medicine. So went back to my undergrad and did my pre-med there for 2 years, and then spent the next 9 years after that training at Tulane, and then back in Milwaukee at a hospital called St. Luke's, not Rush here in Chicago, the other one up in Milwaukee, and then moved back to Ecuador in 1997. This is the organization that we started, and let me tell you a little bit about how this started, because it's easy to talk about what you're doing 20 years later, but the hard stuff is always at the front end. First of all, for those of you who aren't real solid in your geography, and when people hear the country Ecuador, oftentimes they think Ecuador, that sounds like Salvador. It's probably right next door, and the equator goes through Central America because that's the center of the earth, so it's probably into, well, no, it's not right, it's not right, it's not right. So it's on the west coast of South America, just below Colombia, and just above Peru. The Andes Mountains run right through the middle of it. For lots of reasons that we don't have time to go into tonight, we picked a rural community about 3 hours outside of the capital. And these are the kinds of people that we take care of. So it's a mix of Indian populations to essentially mestizo populations. Average income is probably about $3 a day per person. Again, predominantly a rural population. We will talk a little bit about rurality later on if we have some time, but let me just say briefly that our perspective of what rural means is a little bit than what you typically would use. Rurality and urban and rural generally are distinguished in our culture by congestion. If there are a lot of people living in an area, it's urban. If there are not many people living there, it's rural, right? Our perspective is much more of an anthropological perspective, and if people are wired in a rural mindset, it doesn't matter how big their community is, and that's important because our second hospital is our second system is in a community of about 400,000 people, and people might ask, well, it's not rural, that's urban, it's 400,000 people. But understand that 30 years ago there were 75,000 people that lived in that community. Where do you think the other 325,000 came from over the last 25 or 30 years? From the countryside, and that'll be important later on. So these are our communities. So this building is important because it's got a really cool car parked out in front of it. This building is important because on the first floor of this building in 1997, we began our healthcare project. So I went to Ecuador, trained as a primary care physician, and I thought the keys to the kingdom of good health was health education, health promotion, and health prevention. So we went to Ecuador and picked this community. Again, if there's time for this later on, we can talk about it. Picked this community because we found a local guy who was really interested in working with us. And so we did a feasibility study. And in that feasibility study, we looked at the attitudes, beliefs, and practices of both the people in the community and the handful of doctors that were in the community. And they basically told us two things. First thing is, we need a hospital. And the second thing was, we will pay for healthcare services as long as you can put those services within our reach. So come up with some financing mechanisms that'll put it within our reach. So we thought that was interesting, and at that time in 1997, self-sustainable healthcare had become something of bigger interest than it had previously. And so we opened up this place on the first floor. It was a room that was probably about a third of the size of this. We were open 24/7, and we tested the theory that people would pay for healthcare services. There was a Ministry of Health, a very small Ministry of Health clinic about 3 blocks away. We charged like 25 cents for an office visit and maybe $5 for a childbirth. And after 1 year's time, we had done like 5 times the number of deliveries the Ministry of Health clinic did, and we did about 5,000 office visits compared to their 3,000 office visits. So it wasn't a perfect test, but it was a pretty good marker that people would be interested to pay for healthcare services. But this is where I actually started learning what it was like to provide healthcare in a rural community, and what it meant to be poor and not have access to good healthcare services. It's probably one of the ugliest manifestations of poverty that you can imagine. So, a 9-year-old boy came into the clinic having been bitten in the back by a snake, a very venomous snake that we have in our community. His mother brought him in 30 minutes after he was bit. And the kid said to me, he's sitting on a gurney, he said to me, "Doc, I'm going to die. I'm going to die." And it caught me off guard, and I kind of regrouped, and I said, no, you're not going to die. We're going to get this taken care of. Well, at that time, we just had this little building. We didn't have any snake anti-venom. We had none of that. I put him in a car, and I shipped him up to the capital. I said, "You're going to be fine. You're going to make it up there. They'll get anti-venom up there." And unfortunately, the boy died about an hour up the road from our hospital. That was a lightning bolt experience for me. And those kinds of experiences on the clinical side happened over and over again. Kids with bad pneumonias, motor vehicle accidents, complicated childbirths. And then the thing that really pushed us over, that pushed me over personally, one day we went out to a community about an hour away from this small town. We were talking to women in the community. I was giving my canned speech on this complication of pregnancy called preeclampsia. In Latin America, and actually throughout the world, it still is one of the leading killers of pregnant women. So I was going over the signs and symptoms of preeclampsia with this community. This woman sitting in the corner, very wise woman, raised her hand and said, "Hey, Doc, so if I get that, what do I do? Where do I go?" And I said, I don't know. I think you're going to have to go up to the Capitol. And at that time, the Capitol was, it would have taken her about 2 hours to get to this town, 4 hours to get to the Capitol. It's at 10,000 feet. It's a different world. It might as well be a different country for her. She lives in a warm tropical area. She's never not been in a tank top, shorts, and flip-flops. Quito's cold. It's a big city. You have to navigate it. How do you get into a healthcare facility? How do you get past the triage station at the hospital, where the triage person is not a nurse or a physician, but it's actually an 18-year-old guard who is just keeping people out of the emergency department? So I said, I don't have a good answer for you. So she said, "So why are you here? Why are you here? Why are you telling us all this?" And I realized at that time that health education, health promotion, and health prevention, they're all great things. They're all great things. But if you don't have the curative services, you delegitimize your prevention programs, and vice versa. And so curative services need preventive services, but guess what? Preventive services need curative services. If you can't offer people in their time of need the service that they need, they're not going to come to see the healthcare system. They're not going to participate in the healthcare system. If they don't participate in the healthcare system, you as a healthcare system don't know what the healthcare problems are of the community, and you can't create health education programs to address that. So they both need each other. In global health, there's an extraordinary amount of attention placed on education, promotion, and prevention, as there should be. But it doesn't ever talk about the curative side of it, which to me is a little hypocritical, because in our own culture, we probably spend about 90% of our healthcare dollars on curative services, and probably most of that in the last 6 months of people's lives. So it's a different standard. But the experience learned from this was that you have to have both. And so we realized when these patients got sick and we needed to take care of them, we needed to send them someplace. And so I said, well, let's just send them off to the hospital. I didn't know what the hospitals were like in Ecuador at the time. And there was a hospital that was about an hour up from the road from us. And the people said, I'm not going there. Why not? Well, because it's a hospital that's run by medical students who just graduated from medical school in Ecuador. And they don't have any medications, they don't have any supplies, they don't have any supervision. They don't know any medicine. And that's not an unfair assessment. Physicians in the crowd here will say, when you graduate from medical school, even in this country, you know how to write a good exam, but you don't know how to take care of patients. You don't take care of patients. So there wasn't the hospital. What there was an occasional private clinic. There was an occasional missionary hospital, and then there were these government hospitals. But they didn't capture, they couldn't take care of the people that we were trying to send from our place to be cared for. Why? The public hospital, as I just described, the private clinic, they might have some bells and whistles, they might even have some docs that know some medicine in there. But guess what you gotta have to get into that place? You gotta have money. You gotta have money to get into that place. And then the third one, and this is part of what I'm gonna talk about tonight, but not exclusively, is the missionary hospital. Now, I was born and raised Catholic. The president of our organization what was a Catholic priest until he passed away a couple of years ago. He was right head of our organization. So we have a lot of Catholics, a lot of Christians in our organization, but we are not a professed missionary organization, not because we don't have any faith element to what we're doing, but more because we're not a missionary hospital because we believe that missionary hospitals tend to fail the sustainability test. What do I mean by that? And there's all different kinds of missionary hospitals out there, but if they're generally characterized by organizations that come either from the United States or Western Europe with a pocket full of money, they build a building and they start rendering healthcare services. They do it in a relative vacuum. It tends to be dependent on outside people and resources and funding. And when those resources dry up, project ends, and people go home, and the community is even more vulnerable than when you first started. So there are exceptions to that, but by and large, that's kind of the concept that we oftentimes see. If you want to study the Albert Schweitzer model of medicine, that would be his model, right? I still idolize Albert Schweitzer, but I think that was an appropriate model for that time, but times have changed. And so our goal was, with this organization, was how do we have to build a hospital? Do we have to go out and build a hospital? And then we thought, well, do the people want a hospital? Then we went back to that feasibility study where they said, we need a hospital. We said, wow, they were right. They knew exactly what they were talking about. They really did need a hospital. There wasn't one available for them. So, enter stage left. We built a hospital. We were one of those organizations that depended on outside funding, personnel, and resources for a long time. But this hospital was built jointly with the municipal government. It was built on municipal property, and it took us about 3 years to open this thing. It's a small hospital. It's about 15 beds. It's got an ER. It's got an outpatient facility. We deliver babies there. It's got a nice lab. It's got an x-ray machine and some other bells and whistles. And this thing started in 1997. You know what the problem is when you open a hospital in a place like this is? How do you make it run? How do you make it work? So it's good to know a little bit of business administration. And I was thinking, wait, I was an accounting major in college. I wonder if I know something about this. That was a joke, right? And so I didn't know much about it, but we had to learn on the fly and spent the next 7 years trying to do something which was a little unusual. We wanted to take care of everybody that could come into the place. We wanted to provide them high quality care. We wanted to offer this 24/7. And it had to be completely financially self-sustainable. We couldn't turn away anybody. That was the goal. And it took us 7 years to figure out how to do it. And after 7 years, we experimented with every conceivable financing mechanism you could imagine. And we could write books on how not to do it. It was an utterly humbling experience. But after 7 years, we can talk about this in the Q&A later on, but after 7 years, the lines crossed and this place became completely financially self-sustainable. One of the things that makes this unique, it's an all Ecuadorian hospital. There are no foreigners in there except me. The place runs a lot better when I'm not there. And so that place, after 7 years, we decided that it was time to think of something else. The other big problem that we had, in addition to the financial self-sustainability, the financial model, was the HR model. So this is how it went down. Quiteños, people from the capital, from Quito, is where our doctors and nurses came from, because that's where most of the health professionals are trained, and that was where the pool of physicians would come from. So they would come down to the hospital, and this would be a pretty typical scenario. A physician would be in the outpatient facility talking to a mom about her child who has diarrhea, and would go over with the mom about hand washing and keeping the food clean and keeping the kitchen table clean, and maybe taking some antibiotics for a diarrheal infection. And the mom would just kind of look at him. Yeah. She'd walk out the door with the prescription, throw it in the garbage can, and go back home. And the physician would throw her hands up in the air and say, "No one listens to me." And the patient would throw her hands up in the air and say, "No one understands me. No one understands me." And so what we realized is that, and this gets back to the rurality discussion we had before, topic before, is that people have different cosmovisions. Even though they're both from Ecuador, they are worlds apart. Quito is modern, it's Western, it's white. Campo is darker, it has a different cosmovision. It's arguably pre-modern. It's arguably modern. And I don't say that in any kind of a disrespectful way. It's just anthropologically, they're wired different. They have a different way to view their health. And so we decided we needed to train our own physicians. And so we opened up a residency program with the Catholic University in the capital and started training our own residents. This is the self-sustainability piece of this thing. You can see where the lines effectively crossed here in 2007 is where the lines really crossed, and we've been financially self-sustainable ever since then. So step forward, and now we've got a small hospital that's doing some halfway decent work out in the countryside. It's doing it in a self-sustainable way, and we're training physicians. And we've got also this electronic medical record that we built ourselves, and it's a paperless hospital. Wonderful, great. Now what do we do? So now the question became, do you want to roll this thing out? Do you want this to become a model that you could try and replicate in other places? Great, well the first thing you need to do is to try and reproduce it once. And so we built a second hospital now, a 50-bed hospital, and in another community about 2.5 hours away, and that opened about 4 years ago. It's a more sophisticated hospital. It addresses some of the issues that we weren't able to address in our first hospital, and also allowed us to take our training program from graduating 8 doctors a year to graduating about 40 doctors. So the residency program grew. We had signed a contract with the Ministry of Health to be able to do this, and this place is on its way. And this is what it looks like from the inside. So it's an operating room like any other operating room. This is a laparoscopic gallbladder that's being done. We've got imaging that's fairly modern. These are CAT scans. This is a CAT scan, this middle picture on the right-hand side. So we're a big believer in applying as much technology that makes sense in our community as possible. People might say, well, why would you need a CAT scan for it? You don't really need that. Well, the fact of the matter is you do need that, because there are a lot of patients that have lesions and problems, trauma, that would otherwise have to be shipped up to the capital. So finding an old CAT scanner from the United States, spending $10,000 to have it shipped down to Ecuador and have it installed, and introducing a new technology in that part of the world, it's a great use of technology. We also, our training model is also a little unique in that we really want to try and do as much modern, up-to-date training that we can, and really the thing that's in vogue now is simulation training. And so we have a simulation lab, and we have the mannequins that we can use to teach trauma, to teach heart failure, to teach complicated deliveries. And it actually is really a remarkable place to be able to train physicians. You can teach team building, you can teach diagnostic skills, you can teach therapeutic skills, and so it's got all the bells and whistles that you would have right here in Chicago. This is just a shot. 2 years ago, we had an earthquake in Ecuador in April of 2016, and we were a big part of the response to that earthquake. A number of hospitals fell apart, and we were asked to be involved in the rescue efforts. This is just a picture to show you how devastating this earthquake was. There's a lot more things we could talk about, and I really want to touch on a couple more topics. But before I do that, there's a lot of people in the audience here that I think have had experiences not unlike this, or have questions about how to do this kind of thing. I just wanted to stop now my monologue for the last half an hour and give all of you an opportunity to ask some questions. Before I do that, let me just say the last thing I want to tell you, if there's any folks here on the younger end of the life spectrum, if you have to get out of here soon, I just want to send one message out to you, and that is the following. This journey that we've been on as an organization, and me personally, really started when I went through that midlife crisis when I was 21 years of age. And I think the fallout of all that is what I was really looking for was something to be passionate about in my life. And I found something to be passionate about. And when you can find something to be passionate about, and you can connect it to some need in the community, that suddenly becomes a vocation. And there are many vocations out there. There are religious vocations, there are other kinds of vocations in life. And I think that it's an important distinction to make, because I think vocations, in contradistinction to careers are retrospective diagnoses, I think. I think when you're 65 and you're about to retire, you look at your resume and you said, I did this, 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 and this. I think a vocation is you're allowed to be much more proactive. Because you're passionate about it, because you're forward-looking, you choose where you're going to take that passion, where you're going to take that enthusiasm. And so as we get on in life, a lot of us discover that we don't have any passion in our lives. We don't have any passion in our work, and sometimes we don't have any passion in our personal lives. If you get lucky and get one of them, you're pretty lucky. If you get lucky and get both of them, wow, that's a great thing. So I just want to throw this shot across the bow. If anyone's in accounting and they want to go into medicine, do it. Do it. Do it. Do it. Anyway, let me stop there. Thank you very much. Fire away with some questions.
We don't have a microphone this evening, so you'll have to project so that we can pick your question up on our recording camera here. I'd ask you please to focus on given the size of our crowd, a relatively succinct question, and please don't mask a question with a preceding monologue that ends with, "Do you agree with me?" Thanks.
Yes.
Hi, my name is Harrison. Thank you for the talk. I'm a med student at Rush last year right now. I was curious about the role of government and how it played. I know you mentioned it a couple times. I just wanted to hear more about how the Ecuadorian government was either supporting you, or was ever an obstacle you guys had to overcome.
Yeah, the government issue is a constant challenge. As it turns out, in Ecuador, the Ministry of Health is the principal provider of healthcare services in the country. say they provide about 50% of all healthcare services. The Social Security system probably provides about 30%, and then everyone else provides the other 20%. So it's an institution that has its challenges. For those of you who have worked in lower income countries, you know the challenges that ministries of health face in those places, so we don't have to spend a lot of time talking about that. But I will tell you that there is a significant amount of institutional envy. And so when you're a small NGO working in the countryside, you're perceived sometimes as doing the work that the Ministry of Health should be doing. And therefore you're perceived as one of those outsiders that's not part of the institution, and worse yet, you might be a foreigner. And so that's a constant challenge. That was a constant challenge in the early years, and many levels. We spent an inordinate amount of time trying to figure out a way to strengthen that relationship. And it's a challenge. It's a challenge. So what helped? With the Social Security system, they're our biggest client in our first hospital. They're the ones that got us to 100% self-sustainability. Too long of a discussion to talk about how Social Security works, but it's a public institute. It's a pseudo-public-private institution, but it's a government-run institution, and we take care of all their patients, and so we have a good relationship with the government. The other thing that helped was we started training their residents. So we had a class of 45 residents the first year from the Ministry of Health system. And so they graduated and went back to their small communities in the countryside where they came from, and they started practicing medicine. So that scored points. What didn't score points was that a real important piece of the training that I was mentioning before is that we teach them to be really critical thinkers about their own healthcare system. And so when patients come into our hospital and they were seen by the public health system first and foremost, we have discussions about, why did that happen? So the woman that has had 3 months of vaginal bleeding as a 45-year-old who finally gets in to get a pap smear, and then a month later gets a result, and then a month later gets colposcopy suggested, and then a month later has it done, and then 3 months later gets the results back from that, who now comes into our place because she's bleeding heavily. She's bleeding so heavily it can't stop, and she's got an exam, a gynecologic exam that's entirely unrecognizable because her cancer. So it's not so much the disease as it is how does this happen? How do you think about how did the system do her wrong? So that doesn't score us points from the Ministry of Health when the doctors go back and complain about their own system. But that's just an important part of what we do. So Ministry of Health, you cannot work this kind of work. You can't do without participation from the public sector. We thought we could do the second hospital model with fee-for-service only, but if we did that, we'd only be taking care of the haves of the world and not the have-nots. So we need the government contract, which we also had now for a second hospital, so that the government contract pays us more than what it costs us to provide that service. Granted, they pay us about 2 years after we provided the service, but they pay us more than what it costs us, so that little surplus is what we can use to cross-subsidize to do the indigent care. Good question. Thank you.
I thought it was interesting when you said that the residents you were getting from Quito were, they're from Ecuador as well, but just very different experiences and perceptions. And I used to be a teacher in Chicago, and now I'm getting my master's in nursing. And when I was a teacher, I'd say that I was from Chicago, but my students were also from Chicago, and they're two very different Chicagos, where I taught and where I was from. So I guess how do you, I can see now in our healthcare system as well here in the US, kind of like a similar dynamic sometimes where context is not always taken into consideration or is frequently not taken into consideration and understood. So I guess how do you see that translating here in such a structured system?
Yeah, people ask that question. How do you are there lessons learned from our study in Ecuador that are translatable? Is that maybe to what we're doing here? I don't know. I don't have a great answer to that question. I don't really have a great answer to that question. I think that our system is much more complex and arguably politicized, and I don't know if I think the technical solutions are there, but that's about 10% of the battle. The rest of it is political and financial. So we could propose some technical solutions, but I think we all know after these last 10 years of healthcare reform that this is not a technical question, this is a political question. And so it takes people with political astuteness to be able to address that. But I think that, and then there's also the cultural issue of one of the things that happens in our hospitals all the time. In our morning report, where we talk about our patients in the hospital, the very first thing we talk about is what's their ability to pay. Are they indigent? Are they Social Security? Are they self-pay? Or do they have one of these other small private insurance pieces? And that's important because most of our decisions are based on financial. This is tough to appreciate as a non-physician, but a lot of the things that we order, that we do for our patients or sometimes to our patients, you might not have to do that. A lot of it is to do it because that's just how we do it. But do you really need to order those blood tests every day? Do you really need that CAT scan? Do you really need this? So if people don't have the ability to pay, you're not going to do that. Now, if there's something they absolutely need, you're going to do it for them. But that discussion never happens in our culture in that setting because someone else is paying the bill. It's just not something that you have to negotiate with the patient sitting right in front of you. So they're all, it's just a completely different context culturally. It's a different set of political rules. Yes, sir.
Initially, you had a priest who was part of the organization. After he passed away, are there still priests involved in the organization?
Not directly. Not directly. Not directly. Yes, ma'am.
Actually, you answered part of my question, is how you got the hospital to be self-sustaining through the contract with government. But can you tell us some of the ways you tried to do it that didn't work?
You got a couple hours?
Just something concrete.
Yeah, sure. So probably the best example that illustrates that is we decided to sell small little prepaid healthcare packages. So for $30 a year for an adult and for $15 a year for a child, you got a series of things that were covered. You got 50% discount on surgeries, a 50% discount on medications, X number of office visits for free, et cetera, et cetera, et cetera. And we spent a ton of time talking to them about how it would work. Pooled risk. I thought everyone understood what pooled risk is, right? So those kinds of discussions would happen. And in order to get people to buy the prepaid healthcare package, we would do all the things that anyone that works in insurance would say, you are an idiot, do not do that. And one of those things would be, for example, a 10-year-old boy would come in with acute appendicitis. They didn't have any money. His dad would say, look, I can't afford the $100 for the surgery. So we'd say, we'll buy the prepaid healthcare package, and that'll give you the surgery for $50 instead of $100. And all you have to do, you don't have to pay for the whole package. Just put a $10 installment down in the package. So the guy ended up paying $60. He put $10 down for the package, paid $50 for the surgery, and the kid went home 2 days later. And then a week later, we hired the guy that we hired on the motorcycle to go out to these remote communities to collect the other $20 or $10 in installments, and never could find the guy. So he bought the package when he needed it instead of ahead of time. So all that did was probably tell the rest of the community, hey, look, don't buy that package ahead of time. Just buy it when you need it, because they're suckers. They'll give it to you when you need it. So we did those kinds of things. And then the other thing that would happen is when people did buy the package and they didn't use the service throughout the entire year, guess what they did in December? They came in saying, hey, I didn't use the services at all this year. I get my $30 back, right? So those are the kinds of things that happen. The other one that didn't work too well was asking mayors of municipalities to make contributions. And so we would ask town councils to support certain kinds of indigent patients that couldn't afford cesarean sections and things like that. And so the mayors we would send the patient to see the mayor, and the mayor would listen to their story, and then the cesarean section was $100. He'd say, okay, here's $50. I'm assuming you can count on your vote in the next election, and so on and so forth. So those kinds of things didn't work. Lastly, another one, there was the drive from Quito down to this first hospital site. You go from 10,000 feet down to sea level, and you go down the western slopes of the Andes, and you cross the equator about 4 or 5 times. It's got spectacular biodiversity there, and there are eco-tourist lodges all over the place. And those eco-tourist lodges make money, but they pay their employees next to nothing to do the work there, and those people didn't have health insurance. And so we initially proposed to the owners of these places that they should insure their employees. And it's a lot safer to keep your employees, it's a lot smarter to keep your employees healthy than unhealthy. And that worked to a certain extent. And then we went back after not getting much of a response and said, you know what, you're not paying Social Security insurance on any of these employees, Social Security health insurance. We're going to tell Social Security that you're doing this unless you buy these prepaid health care packages. No. And that didn't work either. In the end of the day, about 30% of the population has the ability to pay. The other 70% don't. And another difference between urban and rural is that this kind of a project in urban Ecuador, like in Quito, it's a lot easier to pull off because you've got a number of public hospitals that can siphon off all the indigent people that can't afford it, so all you have to do is take the paying customers. But if you're on the countryside and you're the only show in town, you have to take care of that entire population. You take care of that entire population. What else?
How large a network of clinics do you have besides the hospitals?
It's 2 hospitals and a couple of outpatient facilities that are not ours that we're partnership with a couple of other smaller NGOs in the community.
David, are you still having to send some people to Quito for certain types of care, or what? Can you handle everything, or are there still complicated things that you can't handle at your hospital?
Yeah, there's still some things we can't deal with, and that's okay. It doesn't cause an existential crisis for us. People that have major motor vehicle accidents, we stabilize them out. People that have children that are severely premature. If someone goes into labor at 30 weeks instead of 40 weeks a term, we tend to ship those people out. Things like cancer. There are a couple of cancer hospitals in the country that can manage those patients, and we don't do those kinds of therapies. So we still send some people out.
David, talk a little bit about some of the graduates of the residency program and what they're doing now.
We've had about 70 graduates over the last 10 years, and I was just talking to Francis about this on the way here this afternoon, trying what it's like for universities to track their graduates and see what they're doing. It's not an easy task to do, and I'm not even sure if universities know what to do with the information they gather. But our goal with our graduates was to either continue to work in our organization, continue to work somewhere in the countryside, or become teachers of family medicine at universities. And of those 3 things, 80% of our graduates are doing one of those 3 things. So we're enthusiastic. We're enthusiastic about that. Another thing that comes up, and it's another commentary not provoked by any question that you have, but it's the kind of thing that people sometimes think about, is that the piece about passion that's really important with this is that, man, most days, especially early on, most days in this kind of work, they're not good days. You're fighting against everybody and everything and not understanding all the cultural cues that are going on around you. People are telling you over and over again, no, 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 it's not going to work, you can't do that. And so if you don't have a passion behind this, if you don't have a bigger vision, it's very easy to get bogged down and just want to go home. You just want to go home. And I think that we've got some of our board members here tonight, but you need an incredible board to support you, but you also have to have an incredible team in country to do this work. You try to do this stuff by yourself, you're sunk. You're never gonna get through it. And so, for those of you that are interested in this kind of work, just know that it's not something that is easily accomplished. I feel like after being in Ecuador for 20 years, I'm just now beginning to understand Ecuadorian culture, and I've been there 20 years. But it's very gratifying work, but it takes a long time to get to that gratifying piece. And the other thing I would just like to mention too is to just say a word about the concept of brigades. These are very difficult, sometimes delicate things to talk about because people don't like to hear them. And frankly, they just don't like to hear them. And when I talk about this, this is more of the influence that my Ecuadorian colleagues have had on me than anything else, because I used to think like this back in the old days. But you know, those brigades are people that go to places for a week and they're primary care physicians and they give out antibiotics, or they give out diabetes medications, or they give out antihypertensives after a week, and they go home, and then the next day they pick another country, and they kind of call this duffel bag medicine. It's just, in our opinion, it's not good medicine. It violates a lot of rules of autonomy within country. It doesn't respect in-country healthcare systems. There's no cooperation with in-country partners. It's a fly-by-night thing, and it doesn't do much good. Now, someone's going to say there are exceptions to that. There are places in the world where there's no alternative, and I get that, and maybe that is the exception. But by and large, the brigade thing is something that is no longer really, from our perspective, certainly in Ecuador and in many places in Latin America, it's not a viable option. The one or two exceptions, there's always, the kids with the cleft palates that need plastic surgery. Those kind of kids can still benefit from this because there isn't a lot of long-term follow-up associated with that. But I could tell you endless stories of when over the years in Ecuador, seeing people coming from outside of Ecuador to do brigade work, and they call it missionary work. And again, this has got nothing to do with faith-based stuff. It's just the development thing and the human side of this. General surgeons come from the United States and go to a public hospital in the capital where other Ecuadorian general surgeons are doing the exact same surgery on those patients. They're now standing back and letting the Americans do that same surgery on these other patients now. Why is that happening? So it's very difficult to talk about this without coming across as a very self-righteous person, but we have to have these kinds of conversations because it's no longer about being a do-gooder. We have to be more sophisticated in how we approach development, and healthcare is one example of that. And so if someone asks you if you want to go on a 1-week brigade to hand out medications in Guatemala, think long and hard about that, please. Think long and hard about that. Yes.
Yeah. So in your clinics and these healthcare systems that you've created, have you always been the only North American professional? Have you always had Ecuadorian medical professionals as part of your services, or have you had a team of other North Americans who got you started?
All Ecuadorian.
Okay.
All Ecuadorian. We occasionally take United States medical students, but the medical student that comes to the United States asking or offering to help are the ones that we don't take. Because we're not looking for any help from students, right? They're there to learn.
And it's been like that from day one?
From day one.
And how did you go about creating those relationships?
Little by
So that
little.
it could be that way from day one?
One at a time. First of all, we didn't open up a hospital day one. We opened up an outpatient facility. And so we didn't need a lot of people. And so with time, I went to the Catholic University in the capital, went to the family medicine department, went to the chair of family medicine and said, I need 2 docs to work with us in this project. So started off with 2, and then just started building on that, and then they had contacts with other specialists in other specialties, and that's just little by little how it grew. Yes, sir.
Just a part question. One is, do your healthcare services include mental health and advantages or disadvantages of having or not having that? And the second part is, given what you're saying about what you have to face, who's providing or make sure that wellness is provided to your staff? That space in which they can process all the those barriers and those before they are impacted negatively by that environment.
Thanks for the question. So the first one, mental health, woefully inadequate. In our province, in our second hospital, 700,000 people in the province, 1 psychiatrist, 3 psychologists, 700,000 people. We don't know what we don't know yet. We still don't know. No one has a handle on mental health in the country, let alone in the community. And so it's an area of research that we're very interested in developing. That would be the kind of thing where I would say I would welcome someone from the outside to help us figure that out. We train our physicians, actually as family physicians. They know a lot more about mental health than I ever learned when I was a resident, because I came from a community where there were psychologists and psychiatrists all over the place, right? So they're very well trained, to a certain extent self-taught, on mental health and mental illness. And it gets even more complicated because a transcultural psychiatry, or understanding mental health, is the perception of mental health in another culture is vastly different than it is in the United States. I'm sure you know that. And so just trying to figure out tools to determine if someone really has clinical depression that needs therapy, that needs medication, is a huge challenge just in that in and of itself. If we were to just, even if we were to just take our own tools from the United States and try and use those in that setting, probably wouldn't be valid, and it would be a disservice. So we have a lot of work to do on mental health. It's a great question. The mental health of our own employees, they're actually really resilient. I'm probably the guy who's most disturbed by this. Everyone else is fine. I'm the guy that's sick. They're used to this. So there isn't. We don't talk a lot about wellness among our staff. We don't talk about resilience. That's another term that has become popular in social sciences lately, is this concept of resilience. And these aren't my original thoughts, but my colleagues in Ecuador laugh at the concept, I'm just sharing this with you, laugh at the concept of resilience. Because they say, you know what you call a poor person who isn't resilient? Dead. Dead. So these people have been resilient their entire lives, and people are now just describing the concept of resilience in the social science literature. That's a little bit of an aside, but I tell you, these people are a lot more resilient than I've ever been. Maybe we should be spending more time on the well-being of our. Why do you ask that question, you might ask?
I don't want to take your time, but briefly, I create what's called supervision, which is not about your, it's not about your technical, but it's about your wholeness, your complete way of being, and how to have time. Well, you speak Spanish. I'll speak in Spanish. You translate it.
Well, you can translate. Your English is better than mine.
So we provide safe spaces where people take time to process how whatever it is they do has an impact on their personal life, and how their own personal life is impacted their professional life. And what I have understood, what I've been doing this only 5 years, but what I'm creating here is helping me to understand that that's an area that most professions are not. Most professionals who are providing services are not taking care of, except for those who are working in mental health, which is still not required, but they do have to have some type of supervision. So that's why I'm asking. I'm providing that service in a hospital in Guatemala, and I'm testing that with a group of nurses, also having the growth and personal professional growth and development plan, and have someone to work with.
Are you a physician?
No, I am not.
So, Just on that note, I just want to say this, I know we're getting short on time, but one other thing I just want to tell people, I know that DePaul doesn't have a medical school, doesn't matter. There are a million ways to get into global health, by the way. Medicine is one of them. I would suggest that it's arguably not even the best one. There are other ways to get in. Accountants can do global health, by the way. Social sciences, nursing, public health. There's just a million ways to get, if you're interested in this kind of work. There's a lot of ways to do it. Medicine just happens to be one of them. I will tell you, probably about 10% of what I do, and this has been like this for a long time, 10% of what I do is medical. The rest of it's all administrative and political and financial.
You know, it's funny that my colleague here and I are providing this experience that I'm talking about to accountants here in Chicago. They're the ones that are opening up to test this area of supervision. So
That's because we're the sickest. Yes,
you touched on one of the questions I was going to ask, and that is, what about training for nurses? In your setting, what would be the role of other non-medical providers in your setting? And have you developed a model for that in your situation?
So we train nurses not as formally as we do physicians, but we're in the process of launching a pretty aggressive training program for nurses that we're partnering with one of the universities in our town. The nursing profession in Ecuador suffers pretty significantly. It's a machista culture, first of all, and so there are generally more men physicians and female nurses. There is the other issue of it being the same amount of time. So it's 5 years for nursing, it's 6 years for nursing, and it's 6 years for MDs. So most people just say, I'll just do the MD thing. Thirdly, because of that perception of nursing as being a second-tier kind of profession compared to physicians, nurses can't accomplish what I always lived in, what I know other people lived in hospitals in the United States. Who runs emergency departments? Physicians? Never. Nurses run emergency. Who runs labor and delivery? Nurses run labor and delivery. So nurses run hospitals, there's no doubt about it. Physicians, we don't like to admit it, we do what the nurses tell us to do. A lot of us. But that does not exist. So that team concept does not exist in Ecuador the way that we'd like it to. And so we're trying to figure out a way to introduce that. That's a cultural challenge that needs a lot of time. What was the second
question was, you started off by talking a little bit about liberation theology and based communities and listening. As your program has developed, do you still have a mechanism in place that takes in information so that as needs change or as needs develop, you're still listening to, if you use like the See Judge Act model of approaching patient care, what's the mechanism used for continuing that process?
Yeah, it's a complicated question. We do surveys every day. We probably do surveys on 50% of all or more of our patients that come in, and we use that information to feedback in our system. But I'll tell you, this is going to sound very unorthodox, but we have we call it casa comunal, kind of a common house in the town in our first community. I have never had a good meeting. And whenever we talk about health, things tend to get politicized. There's always someone there who's got an axe to grind, who's got a political agenda. And most of the time, those meetings get really, really politicized and we don't get too far. So having other smaller group meetings outside of a large town-wide meeting tends to work the best. The divisions in town, I've always been fascinated reading the literature, how people talk about community unity. And my little experience and experience of my colleagues, we tend, I don't know if it's just us, but we tend to see more of the community conflict than we do the community unity. And healthcare is a perfect example of that, of how it changes. So we do listen, but we listen via more via questionnaires and surveys than we do in group meetings.
Yes. Speaking of climate risks that you may have experienced or anticipate, what do you see in terms of impact on public health and in terms of care delivery, either that you had to change in the past or changes in care delivery going forward?
Probably the best example, that's a broad question with a long answer, long answer to it, and I don't have the answers to most of them. But I can just tell you anecdotally, one of the things that we've seen as an impact of climate is our two diseases that are both transmitted by mosquitoes. One is called dengue, that's transmitted by one kind of mosquito, and malaria that's transmitted by another kind of mosquito. We used to see 300 cases of malaria a year in our first hospital. Now we don't see malaria in years. We see endless numbers of dengue patients year round. We think that something has happened in the climate that has allowed that dengue mosquito to out-survive or out-compete with the malaria mosquito. It's a topic of research. We'd like to do more research on that. And we hope to be able to do that. We have a small connection with the University of Wisconsin. They've got an ag department and they've got an environmental health school that is pretty interesting. So we'll be able to do some more with that.
I have 3 questions.
3.
Do you have a plan to expand? The second one is that you have board members who are Ecuadorians. And then the third one is that being a Caucasian, a North American Caucasian man, do you think like you had an advantage with dealing with the government than maybe in comparison with maybe a native woman from Ecuador?
Well, I'll answer the last one first. About my advantage of being a white American male. I was told early on that would be an advantage. I've never perceived it as an advantage. I've seen it really more as a disadvantage when dealing with things like the Ministry of Health. There's some things about being in a community like that. There's the gringo effect. There's a little bit of that potentially is positive. But by and large, I don't see it as an advantage. When I used to try and go in to negotiate with the Ministry of Health or with the Social Security system, it never went well. It never went well. We have to collect from the Social Security system. We average about almost $1 million a year in billings to the Social Security system. The person that has had the greatest success in collecting from the Social Security system is a mestizo woman, a very humble mestizo woman from our community who lives in our community. She graduated from high school. We took her to work at the front desk. She's now graduated. She's the CEO of our hospital in Pedro Vicente Maldonado right now. She's a very humble, very mild-mannered person. When she goes into Social Security to collect, they pay her. I think it's got a little bit to do with, without getting into constitutional philosophy, I think that Ecuador is a country that believes much more in equality than they do in liberty. I don't think you can have equality and liberty, equity and liberty. I think they're two very difficult things to espouse as a nation. Ecuador puts much more emphasis on equality than they do on liberty. Now that's not across the board, it's just a personal comment. That's one thing. Expansion, I think that we talked earlier about expanding and trying to create more hospital models and go that route. I don't know if we're going to do that. I can tell you personally, it's killing me to think about even trying to do another hospital. So I'm not all that interested in trying to do this again in terms of raising money and doing all those things to build a building. I think that what's more effective now is that if we've got a 2-hospital system, we've got outpatient facilities, that we can consolidate that and we can continue our training program and we can continue to have public-private partnerships with the government. And the other thing to talk about, we also have a scientific journal that we publish every 4 months on topics that are very relevant to us and to people in the country of Ecuador. And then we have a medical manual is basically the equivalent of, there's this thing in medicine called the Washington Manual that every self-respecting medical student walks around in a white coat and a pocket. It just basically tells you how to do everything so that you don't look like an idiot the next morning when you're rounding in patients. That thing is not a particularly useful tool in a place like Ecuador because it'll do something like just making an example of you. If a kid falls 15 feet from his house, from his bamboo house in Ecuador, you can take the Washington Manual and says, get a CAT scan. So it ceases to become a useful tool. It's just not, it's not contextualized for rural Ecuador. So we had to build our own version of the Washington Manual. And that thing's online now, and that thing is now getting about 10,000 hits a month from about 6 or 7 different countries where rural physicians are practicing. So I think our expansion, if it's going to be that, if it's going to be anything, it'll probably be more on policy side than it is on operations side, because I think that's going to be the bigger impact, is to try and influence policy. What was the third one?
It's like board members or even.
Oh yeah, we have board members that are Ecuadorian. So we have 2 boards. We have a U.S. board where some of them are Ecuadorians, and then we have an all-Ecuadorian board in country because we need the legal status in both cases. Michael, have we time up?
I think we should leave time for people who want to say thank you personally to you, but on behalf of the university, thank you so much.